Hello everyone, my name is Dr. Prateek Joshi and I'm an orthopedic surgeon working in Pune, Maharashtra. Now, first and foremost, I hope you guys are staying safe in these times of coronavirus, and a huge thank you to MEDUSANE India for the opportunity to work with them. So without any further ado, let us move on to today's module, which is a case examination module for Congenital Talipes Equino Varus, or CTEV, which is a common case in the MBBS parlance for orthopedic short case. Now, this is going to be a short module because I would not be going too much into the theory or the pathophysiology of CTEV. For that, we have an entire specific dedicated module on CTEV, and that is on the channel, that is Rapid Revision of Orthopedics by Dr. Prateek Joshi. Now, the name of the channel is at the bottom of your screen, and the link to the channel is in the description of this particular video. So I request you to please take a look at the theory behind CTEV before you actually start watching this video. And here we will be covering the examination points of CTEV. Now, in case history, now CTEV is a case which is entirely in the cold orthopedic domain, and because of that there will not be a very long standing history of trauma or a very long standing history of disability. What we do need to ask in the case history firstly is the neonatal history, where neonatal and perinatal factors such as any birth asphyxia, the birth order of the child, any improper positions of the child such as a breech delivery or frank breech or any of these should be asked. Secondary, of course, is the family history, where you have to ask for any syndromes or syndromic associations in the immediate family or the blood relatives of the child. Also, any history of consanguinity or any history of marriage within the genetic pool should also be asked. Third, any other significant trauma. Now, we just started this slide by saying that not a traumatic history will be obtained, but having said that, in any and every orthopedic case, always be sure to rule out trauma. And therefore, a small note can be made at the end of your discussion saying that no history of significant trauma has been found. And lastly, we should look and ask for syndromic associations. So, a knowledge of the milestones of the child and any delay in the milestones apart from any abnormality in the development should be asked. Now, let's take a quick brief look at the pathoanatomy. We will not be spending a lot of time on this because of the presence of a dedicated module for this. So the first is skeletal or intraosseous pathoanatomy. So the main crux of the intraosseous pathoanatomy is that the bones are small and dysplastic, such as the talus, which has a shortened neck and a small body, and not only that, it is spatially deformed, which means that it is medially and plantarly deviated as compared to its normal position. Now, the second is the muscular deformities, where microscopically you will find an atrophy of type 1 muscle fibers. Therefore, since there is an atrophy and a less number of type 1 muscle fibers, there is an imbalance between the type 1 and the type 2 fibers. Moving on to ligament and capsule, that is interosseous anatomy. Different from intraosseous, the interosseous anatomy is also distorted in terms of a short and contracted articular capsule, and the ligaments around the ankle are also contracted, thin and short. Now, the entire details of these are available on the CTEV module on the channel Rapid Revision of Orthopedics by Dr. Prateek Joshi. Please read them if you have any confusion regarding this. Now, in the examination, the first is to go for inspection. Always remember, the child must be exposed adequately. The bilateral lower limbs should be exposed from the groin all the way to the tip of the toe, and the child should be in a comfortable position, ideally with the attender. Moving on. While inspection, a full head-to-toe inspection should be performed. In the head and the upper body, you should look for stigmata of neurofibromatosis, cafe au lait spots, any other soft tissue tumors, any other skin pigmentation leading to a suspicion of neurocutaneous markers, any other syndromic associations, such as always a smart option is to take a look at the number of digits and the formation of the digits in terms of the shape of the nail bed and the morphology of the tip of the fingers in order to rule out any of these syndromic associations. Also, a good option is to flip the child over onto its back and examine the spine to rule out lesions such as meningomyelocele or spina bifida, which are often associated with these. Now, a lot of these arthrogryposis or developmental dysplasia of the hip and other conditions are associated with congenital Talipes Equino Varus. Now moving on to the local inspection. In local inspection, as we said, the bilateral lower limb has to be exposed from the groin to the tip of the toe, and we should look for, firstly, the deformity should be seen and described, the number of toes should be seen, the morphology of the limb should be seen, and any other morphological or gross deformities such as hemimelia or curving of the tibia or any absence or excessive skin creases, these should be noted. Also, the inspection of the upper body for cafe au lait spots and other neurofibromatosis markers should also be taken to the lower body. Moving on, the severity score, which is used to assess the CTEV, is called as the Pirani severity score. Now, Pirani severity score is a total score of 6 points, 3 for the midfoot and 3 for the hindfoot, and each of these has a score of 0 if the category is present very mildly or is absent. It's a score of 0.5 if it is moderate present, and if it is extremely severe, it is a score of 1, and therefore the highest Pirani score is a score of 6. In case of midfoot, you have the curved lateral border, the medial crease, and the head of the talus, the amount of coverage of the head of the talus. In the hindfoot scores, you have the posterior crease, the rigidity of equinus, and the empty heel sign. Please note that when we have midfoot scores, they are referring to adduction of the forefoot, and when we have hindfoot scores, they are referring to equinus deformity, and therefore a higher midfoot score refers to a more adducted forefoot, and a higher hindfoot score refers to a more severe equinus deformity. Now let us take a look. The first is the curved lateral border. Now if the lateral border of the foot is parallel to a perpendicular finger placed next to it, then the score would be 0. If it is slightly curved and more towards the forefoot, then it is a score of 0.5, and if it is severely curved as in this picture, then it is a score of 1. Moving on, we shall inspect the medial crease. The absence of a medial crease is a score of 0. The presence of a shallow medial crease is a score of 0.5, and the presence of a severe or a deep medial crease like this one is a Pirani score of 1. So here we have a Pirani score of 1 for the medial crease as well, and a deep medial crease refers to the highest degree of adduction of the forefoot. Moving on, we should take a look at the talus. Now if the talus is palpable and if it is reducible, these are the two things that have to be seen in the talus. Now a non-palpable or a non-prominent talus is a Pirani score of 0. A prominent or a palpable talus which is reducible by applying pressure with the thumb and using it as a fulcrum and abducting the forefoot to try to reduce the talus. If it gets reduced, it is a score of 0.5, and if the forefoot adduction is rigid and the talus cannot be reduced using this maneuver, then it is a score of 1. Now in this case, although we are applying a certain amount of abduction and we are trying to push the talus inside, this was an irreducible talus, and therefore another Pirani score of 1. Therefore, so far in the mid-foot examination, we've had a severely curved lateral border, a deep medial crease, and a irreducible talus, and therefore the mid-foot Pirani score for this child is a score of 3, which is the maximum score for midfoot. Now moving on to hindfoot examination, we'll look for a posterior crease. Remember, the posterior crease at the top margin of the heel would be deeper with a deeper degree of equinus, and therefore the absence of a posterior crease is a Pirani score of 0. A shallow posterior crease is a Pirani score of 0.5, and a deep posterior crease is a Pirani score of 1, and this is a significant and deep Pirani 1 posterior crease. Moving on, rigid equinus. Now this is again a dynamic test where we are trying to reduce or we are trying to correct the equinus. If the equinus is easily and completely correctable, it is a Pirani score of 0. If the equinus is correctable partially with certain degree of difficulty, it is a Pirani score of 0.5, and if the equinus is uncorrectable or irreducible, it is a score of 1. In this case, we had a Pirani score 1, rigid equinus. Last but not the least, we have to look for an empty heel, which means that because of the malposition and the dysplasia of the calcaneum, in this case the heel would not allow palpation of the calcaneum, which means that if we palpate the heel with the thumb or with the index finger, and if we are able to feel the calcaneum completely, it is a Pirani score of 0. If we can partially feel the calcaneum, it is a Pirani score of 0.5, and if we cannot feel the calcaneum, it is a Pirani score of 1. In this case, we could just partially feel the calcaneum, and therefore this is a Pirani 0.5 empty heel sign, and therefore the total hind foot score for this patient was 2.5. Now, Pirani scoring is pretty much the entire examination of congenital Talipes Equino Varus at the undergraduate level. At the postgraduate level, there are many other things to examine. In the presence of any syndromic associations, or in the presence of cafe au lait spots, or in the presence of any spinal deformity, of course the examination of that particular deformity will have to be added. However, in this case, the diagnosis which you would give would be in the following format. This patient of mine, a 4-month-old child with a history of in-turning of the feet since birth, currently having a disability of inability to perform assisted walking and the deformity of the foot causing discomfort to the child. Therefore, my diagnosis is a Pirani score of 5.5 in a 4-month-old child with bilateral congenital Talipes Equino Varus in the absence of any gross syndromic, systemic or spinal anomaly. This would be your diagnosis. So this was our quick module on the examination of congenital Talipes Equino Varus. My contact email is here on the slide, and you can always message me on Facebook or Instagram as well. And like, share and subscribe, and hit the bell icon to get notifications. Do subscribe to both the channels, MEDUSANE, which is the parent channel, as well as my own channel, that is Rapid Revision of Orthopedics by Dr. Prateek Joshi. So thank you very much and have a nice day.